Thank you for your kind introduction, Chairman. My name is Jung-Joon from the Korea University Annam Hospital. It's my privilege to present here. And my topic is the bicuspid aortic valve and TAVR. Let's see the case. So 82 years old man, history of hypertension and coronary artery disease, and underwent RCA PCI in 2015. And he had the symptomatic with dyspnea of resorption DIA class 3 and 4. And he had the bicuspid aortic valve and dilated ascending aorta about 48 millimeters. But the ST score is quite low, 2.6. So at finding there is a bicuspid valve, and as you can see, there are severe calcification between the left LCC and NCC. And CT finding says that annulus area is 400 and LVOT area is 387. The parameter is quite small and ST junction is quite big. The CT showed that the calcifications from aortic valve to mitral valve between the NCC and LCC, there's long calcifications. And the aortic angle is quite steep, so which is called the horizontal aorta. So, which strategy do you prefer to this patient, SAVR or TAVR? There is a recent population for the long-term morbidity of the bicuspid aortic valve was published. If the bicuspid aortic valve patient did not die in other causes, the 90% of morbidity have chances to from the bicuspid aortic valve. The first thing is the surgical morbidity is about the 70%, and the second one is the aneurysm for surgery for aneurysm in 27. Interestingly, the infective endocarditis is quite higher than the aortic dissection. And as you can see, there is a typical there are two types of clinical presentation in bicuspid aortic valve, and typical valvular aortopathy and complex valvular aortopathy. Fortunately, the typical valvular aortopathy is quite comparable regarding the mortality compared to the general population, but the complex valvular aortopathy patient does not. The bicuspid aortic valve is a congenital heart disease, and so we should consider about the familiar histories. And screened family, about 24% has a bicuspid aortic valve, and also autodilatation with valve is 30%. The main issue for the bicuspid aortic valve is the timing of the aortic valve replacement. There's a difference between tricuspid valve and bicuspid valve. Bicuspid valve patient had underwent surgery in 2 cases earlier compared to the tricuspid valve patient. So nowadays we talking about the life management patient with severe AS, but the patient who had younger than 70 or 60, there are lots of combinations for SAVR followed by TAVR or TAVR followed by SAVR. So it may bring some various considerations or durability or coronary access, as Dr. Gruber says. Another consideration for the bicuspid aortic stenosis is anatomical considerations such as aortic valve fusion morpholotypes and severity and distribution of leaflet calcification and even the aortopathy. So we have 2 kind of treatment options for the bicuspid aortic stenosis, and as you can see the SAVR, but now the TAVR is close up to SAVR in rate. And the comparable in hospital outcome, but as you can see, there are more bleeding and more pacemaker implantation in the TAVR group. And there is uncertainty to the future progression of aortopathy in the bicuspid aortic valve disease, and there is no randomized control trials for the versus between TAVR and SAVR. Also, the standardized valve sizing is still lacking. So we try to avoid oversizing in heavy calcified valve because we try to avoid rupture. The safety is first. So there are lots of sizing patterns like annular sizing or supraannular sizing and balloon sizing. So no rules, and just case by case. But the CT have provided valuable information for green zone for the suite of TAVR, like no calcified Lafay or excess leaflet calcification, or no dilatation is green zone for the TAVR in bifurcation, bicuspid aortic valve. But the red zone, the calcified Lafay plus excess leaflet calcification and calcified Lafay with dilating ascending aorta may be preferred to the suite for the SAVR. So the CT is important for the bicuspid aortic valve because until APCIS performed the bicuspid aortic valve-based population, the computed tomographic-based anatomical assessment may guide the optimal therapy in patients with bicuspid anatomy. So sheet provides lots of information, including leaflet numbers and Lafay and leaflet calcification, sinus dimension, sinus asymmetry, intercommissural distance, and coronary ostia. And moreover, the visualization of the interaction between transheart valve and overannular and supraannular anatomy. So there is a multicenter registry. It shows a procedural clinical outcome according to valve morphology. So as you expected, calcified Lafay plus excess leaflet calcification has a poor outcome regarding the aortic root injury or second injury and conversion to surgery, and also more PV leak. So there are lots of commercially available transheart valve, but you can, as you see, the only two valves achieve the CE mark for the bicuspid aortic valve, and other valves are not still investigating for the CE mark. So the bicuspid aortic valve for TAVR, that is what we know is a feasible and safe and comparable similar surgery in TAVR. Maybe newest generation transheart valve may better clinical outcome, and CT is mandatory. But still, there is high risk of stroke and high risk pacemaker rate and rupture risk and more PBL. And still remain questions about the anatomic feature, which favorable and which unfavorable. And optimal CT scan sizing method is not have some certainty, and also durability issues still remain. So we need randomized control trial and large cohort. So I bring some cohort. It's a large studies in recent published JAMA 2019. So 92,000 patients with SAPIEN 3 TAVRs in the STS and ACIS TBT registry, and there are 2,700 bicuspid aortic stenosis SAPIEN 3 patients and 79,000 tricuspid AES SAPIEN 3 patients. After the PSM matchings, annual size and LVEF is quite larger in the bicuspid AES. Before the matching, the tricuspid valve is a poor clinical outcome. So interestingly, the bicuspid is more better clinical outcome in regarding the mortality, but not different in the stroke. Maybe it depends on the tricuspid valve patient has the older and bicuspid is younger, is maybe depends on. So after the matching, there's no difference both or cause mortality stroke between the tricuspid and bicuspid valve. And after the matching, the bicuspid aortic stenosis with the balloon expandable valve conversion to open surgery and annulus rupture is high compared to tricuspid aortic stenosis. And there is no statistical significance. The need for second valve chance is numerically higher. But how about in the low-risk group of the bicuspid valve, in which who had a balloon expandable valve? There is quite a promising result for the tricuspid valve, and bicuspid valve is more better clinical outcomes, but not in significance. But there is no difference in procedural complications, including conversion to open surgery or need for second valve. Then how about self-expandable valve? Self-expandable valves show the comparable result between the tricuspid and bicuspid valve, and bicuspid almost 10% in the 1 year for the all-cause mortality, but still there's remained more PBL, mild and moderate severe PBL is higher compared to the tricuspid valve. The recent study is reported in JACC. In the About low-risk trial, there is a bicuspid TAVR valve is quite a promising result. Is 4.1 is all-cause mortality or disabling stroke. It's better than tricuspid valve, even more the SAVR. And there is no significant hemodynamics differences during the 3 years. Then, how about the SAVR? So all patients undergoing surgery, aortic valve replacement is 500,000 from the 2012 to 2018. After exclusion, final quote is 65,000, and bicuspid aortic valve 9,000 patients, and tricuspid aortic valve is 56,000 patients. How's it going? So as you expected, the bicuspid aortic valve has a good result for the mortality compared to tricuspid aortic valve, as the previous slide. And we know there is a elderly is more than tricuspid valve, but the risk when after the risk adjusted curve, there's still 28% risk reductions in bicuspid aortic valve compared to the TAVR. So we now comparison of results among the studies. The TAVR with balloon expandable valve and TAVR with self-expandable valve with all risk, 30 days mortality 2.6 and 10.4 is quite higher compared to the SAVR all risk 1.7 and 3.2. But when you see the TAVR and balloon expandable valve and self-expandable valve in low risk group, it's 0.9 and 4.6 is quite comparable is SAVR with low risk 0.9 and 2.7. So the guideline says different things about the bicuspid aortic valve. The AHA and APCIS guideline says TAVI may be considered as an alternative to SAVR, but ESCCN and EACTS does not. So there are roadmap going forward to address knowledge gaps. Of course, we need some RCT for the SAVR versus TAVR in patients with bicuspid aortic valve at low and intermediate surgical risk. And first, we think we have to do some unified and nomenclature based on the MDCT imaging, and also patient selection and tailored procedural planning and long-term clinical follow-up and should be addressed for the reduce the knowledge gaps. So let's look back to the TAVR procedures. So he had no significant stenosis of the coronary artery disease, and in aortogram there's a same calcification. It's LV aortic valve to LVOT. So we done the pre-balloon for the GMAT 20 millimeters, and the balloon is sufficiently open, the valve, and we're going to the SAPIEN 3, 23 millimeters, and safely with the tachypacing. So the final result was mean pressure gradient 1.3 and AR index in 33 and no PBL leak. So here is my summary. The bicuspid aortic valve is associated with heterogeneous morphology, eccentric pattern of calcification, leaflet asymmetry, angulated artery root, and arteropathy that can pose risk. And TAVR is a good alternative treatment option for bicuspid aortic valve patient with symptomatic AS, as well as showed comparable result for the SAVR bicuspid aortic valve in low-risk group from recent large cohort analysis. But we still may need RCT of TAVR versus SAVR. Thank you for your attention.